Hi, everybody. This is AJ Heightman, Editor-in-Chief of JEMS, and welcome to today's webcast on Making the Leap to Improvement Science, which is being brought to you today by the American College of Cardiology in collaboration with the Center for Systems Improvement. Just a few housekeeping notes for you before we get started. This presentation is both live and interactive, so you can ask questions at any time by clicking on the Ask the Question box in the presentation window, then click Send. The questions will be answered during the Q&A portion at the end. That'll be moderated by Mick Gunderson, who's president of the Center for Systems Improvement. And then I'll be triaging those questions. If you have any technical problems, please alert us through the Ask a Question box, and a member of our staff will take care of your technical problems for you. Today's webcast includes streaming video, so once the video appears and begins playing, you can enlarge the video player by clicking on the double arrows in the bottom right-hand corner. Also, if you're running pop-up blocking software, you'll need to disable it to view the webcast. In addition, it's recommended that you close all other applications for better performance on your computer. And for your convenience, this webcast will be available on demand within 24 hours of this live event. A reminder email message will be sent to all registrants with a link to the archives. It can also then be reached at gems.com/webcasts. I want to thank our sponsor and introduce our speakers now. The American College of Cardiology and the Center for Systems Improvement would like to welcome everybody to this first module in their EMS and Systems of Care webinar series for taking clinical quality to the next level. Now it's my pleasure to introduce the speakers that will be speaking to you. Dr. Michael Valentine is president of the American College of Cardiology. He's also the senior cardiologist at the Struzevantz Cardiovascular Center with Center Health in Lynchburg, Virginia. Also joining us is Dr. William Oetgen, and Dr. Oetgen is also a highly respected cardiologist. He's the American College of Cardiology's Executive Vice President for Science, Quality, and Publications. I'm going to let Dr. Oetgen introduce Mick Gunderson at the end, and I'm now going to turn the presentation over to Dr. Valentine.
Thank you. Since many of you in EMS may not be familiar with the ACC, let's start with a brief introduction to our association.
One organization, more than 65 years. With more than 52,000 members worldwide, we provide care for millions of heart patients every year. Since 1950, we've helped decrease death rates from heart disease by over 60%. Every day, we're working to discover new scientific breakthroughs in cardiovascular medicine. We're continually educating our members and helping to train a new generation of cardiovascular health professionals. We're developing clinical guidelines to ensure best practices in treatment. We're sharing decision-making with our patients. We're promoting healthy lifestyles to help people live longer and better. We are committed to the vision of reducing heart disease and improving heart health. We are the American College of Cardiology.
Over the years, the ACC has become a place for the entire cardiovascular team to collaborate in efforts to improve care and advocate for our patients' needs. In addition to cardiologists, our membership includes hospital and cardiovascular service line administrators, cardiovascular nurses and technicians, emergency physicians, and we will soon be rolling out a new membership category for EMS professionals. More information on that will be coming out soon. We are introducing that membership category in recognition of the pivotal role that EMS and how it influences the patient's entire course of care throughout the rest of the healthcare system. EMS initiates life-saving triage and care before hospital arrival, putting the patient on the right trajectory at the onset of their illness, particularly for high-risk, time-sensitive emergencies like STEMI. These actions can dramatically improve patient outcomes and reduce the overall costs of care. As EMS continues to expand into mobile, integrated healthcare, EMS may also come into play an increasingly important role in prevention and post-acute cardiovascular care. Professional education with topics such as this particularly at systems and at a leadership level, is one of the many initiatives that the ACC is going to be undertaking to improve our support of EMS and systems of care. Typical of this is our VHAC project in Virginia, where we are intimately involved with physicians, EMS, emergency room physicians, and others. It is the perfect example of how all of us can work together to improve team-based care and to improve the quality of our patient care every day. Now I'm going to turn this over to Dr. Bill Oetgen.
Thanks, Mike. The ACC has several quality offerings that operate in the acute coronary syndrome space. Our ACC accreditation services offer chest pain center accreditation. It's a program designed for hospital cardiovascular teams that are focused on the best care of ACS patients. We also have our clinical registries that support quality improvement and research in cardiovascular care. With 10 different clinical care registries that gather data from approximately 2,400 hospitals and 8,500 outpatients, they form a comprehensive network of cardiovascular care providers committed to delivering evidence-based cardiovascular care, improving patient outcomes, and lowering healthcare costs. One of those registries is the Chest Pain MI Registry, which until recently was called the Action Registry. It has over 1.5 million patient records spanning over 10 years of progress and quality improvement for the care of myocardial infarctions. It gathers detailed information about episodes of care for both STEMIs and NSTEMIs, and some of that information comes from the EMS patient care reports inserted into the hospital chart. The EMS agency's state EMS ID number is one of the data fields that is captured in the registry. That's going to make it possible to sift through all of the registry records to look for ones corresponding to a particular EMS agency's state ID number, and that will allow us to create reports for your specific EMS agency. These reports will be offered in an online format in a new service called NCDR eReports EMS. It will consolidate the information about all of an EMS agency's AMI patients across multiple hospitals into a single report to help guide the EMS agency's cardiovascular quality management program efforts. We're not going to get into the details right now because more information about NCDR eReports EMS will be offered in a future webinar. But today, we start our EMS and Systems of Care webinar series for taking clinical quality to the next level. There are already plenty of very basic and very general quality management training programs available to healthcare professionals. This series will be a bit different. We plan to focus the information on cardiovascular care, even though much of the information will also be applicable to other types of care, as well as non-clinical quality management. The examples to be used will be more oriented to those with an interest in EMS and CV systems of care, particularly for STEMI. The first module in the webinar series is about making the leap from a typical quality improvement structure as seen in most EMS agencies and hospitals to ones that use a more sophisticated approach based on the concept and tools of the scientific method. This approach is commonly referred to as improvement science. The lead instructor in this webinar series will be someone familiar to many of you in the EMS and cardiovascular systems of care communities. Mick Gunderson has a long and diverse background in EMS quality and cardiovascular care. He has been involved in emergency health care for over 40 years in various leadership, managerial, and frontline clinical roles. Currently, he is president of the Center for Systems Improvement, a firm that specializes in system design and value improvement for high-risk, time-sensitive care. The ACC is working with the Center for Systems Improvement to develop our EMS and systems of care programs and services. I'll now turn the presentation over to Mick.
Thank you, Dr. Valentine and Dr. Oetgen, for your kind introductions. We plan to offer a new module in this webinar series about every other month, and we're going to start off this first one with a very brief overview of some quality management history, along with more current events that should help put much of what we will be talking about in future webinars into better context for you. If you're watching this live, please enter any questions you may have directly into the webinar platform. If you're listening to this from the archive recording, please email questions to me at mic@improvethesystem.com, and I'll do my best to answer them. So I think it's important to include a bit of information about the history of quality management because it's helpful in understanding many of the other things you will learn about quality and value and how they relate to healthcare, EMS, and high-risk, time-sensitive systems of care in particular. Many of the other courses in quality management gloss over or dismiss the history and the theory that underpins it, but I think there are huge lessons to be learned from the history and the insights to be gained from understanding the theory. So as we all continue to learn more about science, improvement, and management throughout our careers, it's extraordinarily helpful to put the writings and tools you'll see into proper context. The approach we're going to take on this and other webinars for EMS and systems of care is not to just teach how to do a task like building a fishbone diagram. We want you to understand the theories and principles of improvement, quality, and value in enough detail to apply them intelligently to the right problems in the right situations and with competence. So we'll try to strike a reasonable balance between theory and how to apply it. With all of that in mind, let's press ahead. One of the earliest strategies to manage quality was the establishment of craft guilds. Master craftsmen banded together in these guilds to establish standards in their respective trades. They promoted and sustained these standards primarily through an extremely thorough and painstaking training process for their apprentices. It took a lot of time and effort to complete an apprenticeship before being recognized as a fully trained craftsman. This strategy dominated for centuries and continues in some forms very effectively even today. Think of medical residencies and fellowships for physicians. Think of field training officer and preceptor programs in EMS. These are remnants of the craft guild model. Around the time of the turn of the 20th century, however, a change in circumstances necessitated significant innovation. The large factories sprouting up needed lots of workers, and they needed to scale up production as quickly as possible. There wasn't time to train them all in the manner of craftsmen. At the Ford plant, their early assembly lines showcased the innovation that addressed this challenge. It was called scientific management. Henry Ford, shown on the left, utilized the scientific management techniques developed by Frederick Taylor, who's shown on the right. The processes that used to require craftsmen were broken down into very small tasks that could be quickly taught and mastered by otherwise uneducated workers. The thinking was done by the industrial engineers and managers who designed the processes and the tasks. This led to the notion of telling workers, don't think, just do your job. The strategy of scientific management was successful, but only to a point. There were a lot of defects in the parts that came off those assembly lines. Inspectors were relied upon to find and remove as many of the defective parts as possible from the assembly line, but not every defect was found. And some parts and assemblies passed inspections but just barely, and as a result, they caused problems in reliability and durability due to their marginal compliance to specifications. Additionally, all the waste and scrap heaps from defective parts and assemblies increased overall costs. So, in search for a better way, history takes us to the famed Bell Laboratories in Hawthorne, Illinois. Many innovations came from there, including some of the work of these three gentlemen. From left to right, we see Walter Schuhart, Joseph Duran, and W. Edwards Deming. In the wake of the scientific management's popularization, they championed the idea that the frontline workers had something meaningful to contribute to improving quality. The frontline worker had insights on problems and processes that the college boys in the front office just didn't have a sufficient understanding or appreciation for. Those uneducated frontline workers were actually quite smart overall. They lived inside those processes 8 hours a day in, day out, and developed deep insights themselves. They had solid and practical ideas to improve quality and value, but were largely ignored in the pure scientific management strategy. These three guys developed and deployed statistical tools that could be used by the frontline workers to detect when a process was starting to drift off target. They promoted policies that empowered the frontline workers to take corrective actions immediately to prevent errors and irregularities long before they would ever show up officially as a defect. These simple concepts led to a transformational philosophy of management in general and the management of quality in particular. Those transformative ideas really took hold in Japan. After World War II, Deming and Duran were brought in by General MacArthur to assist the Japanese in rebuilding their manufacturing industries. They were very open to the ideas that Deming and Duran pioneered with Schuhart at Bell Laboratories. Ironically, U.S. industries were less interested at that time in adopting those innovations from Bell Labs. U.S. factories were focused instead on manufacturing volume over quality to meet the incredible demand for U.S. goods after World War II, with the industrial infrastructure of Europe and much of Asia in ruins. The industrial engineer Taiichi Ohno on the left and his employer E.G. Toyota on the right built Toyota on these principles, and they were incredibly effective. They evolved the ideas introduced by Deming and Duran even further, and their methods came to be known as the renowned Toyota Production System. This was the precursor to what we now call lean management. In the US, late to the game in the 80s and 90s, but still taking the lessons to heart, Motorola developed its own quality methodology based on the principles of Schuhart, Deming, Duran, and Toyota, and called it Six Sigma. Six Sigma and lean tools and strategies are still widely used with great success today. But what about healthcare? Healthcare did not really get involved in the quality revolution until much later in the 20th century. Healthcare did not think it had much in common with the innovations made in quality by the manufacturing firms. So for quite some time, healthcare quality had many traits more in common with factories of the earliest 20th century using methods from the era of scientific management, including reliance on quality by inspection. In that era, the business case for healthcare quality was about preventing lawsuits from patients that had received poor quality care when problematic care was identified by lawyers or by the internal hospital quality police. So the unfortunate employees associated with the defect in care were admonished to be more careful. They were given remedial training, negative notations were made in their employee records, and all of this was based on the premise that if the healthcare organization provides counseling and corrective education, and if the employees are reminded to be more careful, then quality will improve. The underlying problem that most managers fail to recognize is that being more careful is a very short-term solution at best. As found by Schuhart, Deming, Duran, and those that followed in the industrial quality revolution, the root cause of the problems was not the workers being careless so much as it was in the design of the processes they operated in. This is no different in healthcare. Then people in healthcare woke up and started to smell the coffee. Dr. Donald Berwick is widely credited with introducing the industrial quality models pioneered in manufacturing into healthcare. He published this landmark paper in the New England Journal of Medicine called Continuous Improvement as an Ideal in Healthcare. This was followed by a landmark book appropriately titled Curing Healthcare. And the swell of interest and support for the ideas they presented led to the creation of the Institute for Healthcare Improvement, which is today widely recognized as one of the leading organizations in the promotion of healthcare quality worldwide. As all of this was unfolding in healthcare, the Joint Commission on the Accreditation of Healthcare Organizations began to implement a program called ORIX to continuously measure clinical quality through performance measures. Hospitals that wanted to be accredited or remain accredited had to track these performance measures. The results were publicly reported as a way to incentivize the hospitals to improve their clinical quality in order to maintain their reputations. Through this public reporting strategy, hospitals started to become publicly accountable for the quality of their care. other public reporting programs followed, including programs from the Center for Medicare and Medicaid, or CMS. Those programs have been expanding beyond hospitals into other care settings to include behavioral health, home health care, skilled nursing facilities, and more. At some point, it is anticipated that any healthcare provider that receives payment from Medicare or Medicaid will be required to participate in performance measurement and submit their results for public reporting. This principle of healthcare organizations being held accountable for the quality of care they provide has been extended into formulas that determine how much they get paid. So now we see public reporting and so-called pay-for-performance programs spreading throughout healthcare. One of the big limitations of these programs is that they establish accountability for quality but not cost. Healthcare providers are mostly paid through fee-for-service models. You provide care, submit for payment, and then get paid. The more care you provide, the more you submit for payment, and the more you get paid. Now, this has some unintended consequences. Good quality care can actually reduce the amount of care that's needed. If better care results in less care needed, then healthcare providers can potentially lose revenue by providing better care. And this creates a huge business and ethics problem. So to resolve it, healthcare in the U.S. is moving towards so-called alternative payment models, or APMs. With APMs, there are financial incentives to improve both quality and reduce costs. That transition is now underway, but it's slow going. The implications, though, for EMS are huge. It sets the stage for incentivizing more efficient systems of care. So, for an example, an efficient and effective STEMI system of care can now be financially rewarded. Newer approaches, like EMS-based mobile integrated healthcare to prevent ED visits by preventing problems, can potentially be paid for with these alternative payment models, as well as using MIH to find ways for dealing with problems in more efficient ways, which also has a way to be paid for through these alternative payment models. Many of those efforts rely on nationally standardized performance measures. Now, most areas of medicine already have such measures, but EMS has been on the sidelines until quite recently. The EMS Compass project was funded by the Office of EMS at the National Highway Traffic Safety Administration to help develop nationally standardized performance measures for EMS. The funding for that has already ran out, but it did establish a process that the EMS industry can use to develop such measures moving forward. To sustain this effort over the long term, the Office of EMS has funded the startup for an effort to build on what EMS Compass started. It's called the National EMS Quality Alliance. It's a consortium of stakeholder organizations that share an interest in developing nationally standardized EMS performance measures. And I'd like to make particular note that the American College of Cardiology has joined the National EMS Quality Alliance to assist in that process. These measures can help guide EMS quality efforts in the near term, and it gets the EMS community ready for pay for reporting, pay for performance, or other types of measures and quality and cost accountability that will come in greater prominence as healthcare payment reform moves forward. Taking all of this into consideration, we can confidently anticipate increasing pressure to improve healthcare quality while simultaneously lowering costs. Healthcare organizations of all types will be held to more and more accountability to measure and publicly report their quality. Their financial stability will depend on their quality and efficiency as alternative payment programs mature and proliferate. These circumstances create powerful motivations for healthcare organizations, including those that provide EMS, to up their game in the improvement of quality while simultaneously becoming more efficient in their use of resources. Hence, organizations will benefit from more sophisticated and effective ways to approach quality and value. And this is driving the growing interest in more scientifically based approaches to quality improvement, which is now commonly referred to as improvement science. The link between the scientific method and the contemporary models for quality management have always been there. But with improvement science, we try to make more explicit use of the scientific method in the design and execution of our improvement projects to improve quality and efficiency. We consider the intervention we make in our improvement project as a hypothesis. We design the project to try to control potentially confounding variables, just as we would in a research study. And we use the appropriate statistical tools for hypothesis testing to objectively evaluate the impact of the improvement interventions. So at this point, I think it's appropriate to clarify some of the other key terminology that's often used to improve quality and value. Two terms that are widely misunderstood are quality assurance and quality improvement. Both are needed in a sound approach to quality and value. Our organizations explicitly design processes for most key activities. Clinically, those processes are often referred to as protocols or practice guidelines or clinical pathways. When we try to assess how well these protocols are performing, we typically look at clinical and operational performance measures. And a common problem in assessing process performance is that many times the process as it was designed is not being consistently followed. While it's okay to deviate when appropriate, sometimes it's simply that many choose to do things their own way and for no particular or defensible reason. So quality assurance efforts are about finding ways to assure that the process is being followed as designed whenever appropriate. But it's crucial to understand that when you're trying to measure the performance of the process your organization designed, if the process design is not being followed, the performance measurements do not tell you how good that process design really is. That's why it's so important to have a quality assurance element in your quality management strategy. Once you have good compliance and can separate out any non-compliant cases that will happen from time to time, you can begin to get a valid measure of your process performance. Without it, you really don't know what's being measured. So quality assurance is not about being punitive or negative. Done properly, quality assurance simply identifies non-compliance and finds ways to increase compliance whenever it's appropriate. As an example, an EMS system might have an ACS treatment protocol, a process design that calls for an aspirin to be given to all patients with suspected acute coronary syndromes unless contraindicated. Unfortunately, compliance to this element of the ACS treatment protocol at the local EMS agency is relatively low. Crews often forget this simple but important step. To reduce the chances for crews to forget and to reinforce its importance, the EMS agency decided to initiate some QA activities. First, they're going to let crews know in their next monthly CME class that aspirin administration is an important clinical opportunity to reduce AMI mortality and present some research studies that demonstrate that fact. Second, they're going to post performance feedback reports on aspirin administration compliance rates by shift and for agency-level performance in aggregate. And third, they're going to try to error-proof the process against forgetting by attaching single-dose aspirin packets to the 12-lead ECG electrodes packet with a rubber band whenever the monitor defibrillator is cleaned and prepped for the next call. Notice they are not changing the protocol here. They are just trying to find ways to improve compliance to it. That's a quality assurance activity. In contrast, quality improvement is about changing the design of a process. From a quality improvement perspective, we would change the ACS protocol process design so that it could become capable of a higher level of performance. So let's consider the process for how an ALS ambulance service acquires 12-lead ECGs on patients presenting to EMS with non-traumatic chest pain. Their crews are following the protocol. They're getting it done pretty consistently in about 10 minutes. But would it be possible to make it much faster? This is where benchmarking and innovation come into play. Benchmarking typically involves an examination of how others performing at a higher level are doing the same or similar things and using those observations to fuel ideas for what parts of those observed processes might be put into a modification to your current process design. Sometimes the benchmarking is done by looking at medical journal articles and research where processes are described. Sometimes it's talking to folks or seeing presentations at conferences. Sometimes best practices are found in email discussion groups. Sometimes it's going on site with another organization and observing directly. At the end of the day, you decide what to change, make the change, work through QA to assure appropriate process compliance, and then see if your results improve. If it does, great. But sometimes you find that you're doing the same things and have similar results to the so-called best practices. That's where true innovation comes in. Try to come up with a unique idea. Make it work. Try to become the new best practices that others benchmark. So let's consider an innovation example. And I realize that some places have already done this, but for the purposes of this example, imagine we've turned the clock back a bit. In this example, imagine that you've just read a research paper reporting much shorter times than your agency for the EMS first medical contact to first 12 lead time interval. You read how they did it by using a pit crew approach, much like crews do with CPR. You take steps to make the change to your protocols and implement training, feedback, etc. Or maybe you already do that and all the other things you've read about. You want to innovate. Perhaps you start to consider opportunities with the BLS engine crews, which usually arrive several minutes before the ALS ambulance does. They could be trained to identify likely ACS cases, but it would be prohibitively expensive to equip them all with 12-lead ECG equipment. However, maybe they could be trained and equipped to apply the 12-lead ECG electrodes before the ALS ambulance with the 12-lead monitor arrives. Whether it was incorporating pit crew choreography or having the first arriving crew apply the 12-lead electrodes before the ambulance with the 12-lead machine arrives, those changes we made to the process design were a hypothesis, and we need to test it with appropriate statistical tools to objectively evaluate whether or not those changes actually made an improvement. Far too often, organizations call an improvement intervention a success or a failure without adequate information to properly assess the true impact. That's one of the big differences between the ways that improvement projects are typically carried out versus the way that improvement projects are done when taking it up a notch with a more rigorous improvement science approach. Another set of terms you'll be hearing a lot about, particularly in this webinar series, are quality, cost, and value. Let's talk a little bit about their meaning in context of our discussions about improvement science. There's several ways to define quality, but the one that is most applicable to quality management is classically defined as the characteristics of a product or service that reflects on its ability to meet a need. To make it a bit more specific to healthcare, it's usually considered in terms of how well a healthcare service contributed to desired outcomes. It can also reflect on how consistent the care processes were with current professional knowledge that shows a link between compliance to a process and an improved outcome. These are typically expressed as clinical standards and guidelines. From an outcomes perspective, we might measure STEMI care quality by the percentage of cases that survive to hospital discharge. We might assess process quality by measuring the percentage of cases that have an EMS first medical contact to device time of less than 90 minutes because the science shows a causal link between the process measure and the desired outcome measure. The sooner we get the patient to the hospital and use a stent to open their artery, the better the outcome. Then we have cost, which is what you pay or expend to get something. And the cost may be in terms of money, time, or other resources. Sometimes costs are looked at from an external perspective. In healthcare, what did the patient and their insurance company have to pay for their STEMI care? Or it might be looked at from an internal perspective. like how much did the EMS agency and the hospital actually spend internally on the care provided to STEMI patients, regardless of what was billed. Most commonly, an external patient-centered perspective is taken on cost measures, recognizing that sometimes there's a difference between what is billed and what is actually paid. That brings us to value. What did someone get for what they paid? Taken together, we look at what we got as a quality measure and what we paid as the cost measure. We can then put quality and cost measures into the value equation, where an appropriately formatted quality measure is in the numerator and an appropriately formatted cost measure goes into the denominator. We do the math and get a measure of value. Let's consider a simple non-medical example first. I've got a field with two identical holes that need to be filled in. I have a limited budget of only $195. And because of scheduling problems, I end up getting two different contractors to help me. I may not have enough money to get them both completely filled, but I'm going to ask each contractor to do as much as they can for what they are paid. The first contractor agrees to help me out for $100, so that $100 goes into the denominator. And the first contractor fills about 40% of the hole. That reflects on how well my need was met, so it's a quality metric and it goes into the numerator. Doing the math, we get a value result, a value quotient of 0.4. I've got $95 left, so the second guy also helps me out. He gets 30% of the other hole filled. Do the math, and we see a value quotient of 0.32. So we got a better value from the first guy, considering both the amount of money we paid, which is the cost factor, and the amount of my need that was met in filling the hole, which is the quality factor. The point is that we can make a numerical comparison between the two scenarios that considers the combined impact of both the cost and the quality. Now, let's apply that approach to systems of care for out-of-hospital cardiac arrest as an example. We will consider two hypothetical communities with essentially identical characteristics, similar populations, demographics, transportation infrastructure, etc. In one of the communities, they have a 55% survival rate from out-of-hospital cardiac arrests with presumed cardiac etiologies that had a witness onset and presented in a shockable rhythm. In that community, we take the population and divide it by the total cost for EMS services, and we get a per capita or cost per citizen figure of $70. In other words, the community spent about $70 per person on EMS. So that's what they paid to get their system, which produced the 55% survival rate. Doing the math, we see this yields a value quotient of 0.79. In the other community, they also have a 55% survival rate, but they only spent $60 per capita. We get a value quotient there of 0.92. This second community provides better value for the money than the first community. Now, we can certainly have a conversation about how the survival rate and the costs are calculated, but so long as we do it fairly and in the same way in both cases, we can have the basis for doing a value-based comparison of performance. That's going to become a major factor in how the performance of healthcare systems are assessed moving forward. So, we've covered a lot of ground so far, so let's recap. First off, we learned that the American College of Cardiology offers chest pain center accreditation and the chest pain MI registry, clinical guidelines and standards in cardiovascular care, and a range of other services. These quality improvement tools support the efforts of EMS and systems of care for high-risk, time-sensitive cardiovascular cases, and they'll be expanding their EMS focus through the offering of NCDR e-reports for EMS in the very near future. We also learned the way the quality has been managed over time has changed considerably. This is especially true in healthcare. We learned that there will be increasing pressure in healthcare to simultaneously improve quality while reducing costs. This means we will have to up our game in terms of how we approach quality. This leads to the notion of improvement science, which brings a more sophisticated approach to our efforts that are more closely aligned with the methods used in research. With an improvement science approach, we consider the change we make in a process design as a hypothesis and design the improvement project and analyze the results with the same tools and rigors that would be used in a research study. We also learned that a sound quality management program includes both quality assurance and quality improvement elements. They play different and very complementary roles. And finally, we learned about how value measures the combined impact of quality and cost. We saw how value can be measured using the value equation. Again, if you're watching this live, enter your questions into the webinar platform. If you're watching the archive recording of this webinar, please feel free to email me at mick@improvethesystem.com. Let's take a look at what questions or comments we have so far.
Thanks, Mick. That was great. My first comment personally is that that's the kind of presentation that every brand new EMS cadet, EMT, paramedic should get when they're in their basic training, so that they really understand why we're asking them to do all of this stuff. When do you think that EMS is going to be required to publicly report its performance, is question one.
Well, AJ, thanks for your comment about the presentation. I appreciate that. But with the public reporting, one of the issues we're facing right now is EMS is still considered a supplier by Centers for Medicare and Medicaid, kind of the same as wheelchair service or wheelchair suppliers, medical equipment, that sort of thing. We're not classified as a provider. I know this is being addressed nationally by a number of organizations, and there's some controversy about that. But if and when EMS becomes categorized as a provider organization, that's when I think the dominoes will start to line up for EMS to start being held accountable for public reporting and all of those other things that we see hospitals and long-term care facilities, behavioral health, et cetera, are already involved with. But even before that, we might see those at-risk payers under these alternative payment models asking questions about EMS as well, because if they're going to be responsible for paying the bills on behalf of CMS or a major local employer, for example, with a self-insured healthcare strategy, they're going to be very interested in knowing that EMS is properly handling the patients, both in terms of quality and efficiency and those sorts of things. So we might actually see this accountability show up sooner than later through those at-risk payers rather than CMS itself.
Yeah, but visionaries like yourself and many others say that it's coming. So shouldn't we be preparing right now with improving our quality and particularly what we're studying and how we're collecting data?
Oh, absolutely. I completely agree with that. And because we know it takes some time for organizations to come to agreement on what measures should EMS be held accountable for, and then developing the data elements in the NEMSIS dictionary, for example, and the associated performance measures through the National EMS Quality Alliance, and then the data vendors, the EPCR vendors, to be more specific, changing the software so that that information is collected so it can generate those performance measures. That's all going to take some time. We're seeing the early phases of those gears starting to turn and moving in that direction in anticipation. So yeah, we really don't have a whole lot of time to waste, because it's going to take some time to get to that point and be ready for when that at-risk payer starts asking the question. My concern is that our pace is not fast enough.
Yeah, and I was just at a conference in Pennsylvania with Wolfberg and Wirth, and they announced, which I think is pretty exciting, that Pennsylvania has just passed a law that's going to require the insurance carriers to pay for care provided, which means it's not going to be tied to transport anymore, at least in Pennsylvania, which I think is a big step forward for first responders, mobile integrated healthcare. Let me ask a question here. How do you include a hypothesis in a QI project?
So if you go back to what I was talking about before with the intervention you make in an improvement project, when you do one of these things, you kind of have in the back of your mind that this change you're considering is going to result in an improvement. Otherwise, why would you even be making the change, right? So what we're simply saying is that when you design a QI project, the change you make, that in itself is the hypothesis. And if we recognize that the change we're making is a hypothesis, and then kind of design the whole project accordingly with controlling extraneous or confounding variables, and then using appropriate statistical techniques to test how well things were before the change and how things were working after the change, and making sure that there is a statistically significant difference between those results. That's what I'm talking about with considering the change you make in a QI project as a hypothesis. So I submit that when you do the project, you already have a hypothesis, but you've never really called it that. So if we recognize it's a hypothesis, then we can see the parallels between how we do a quality improvement project and how we can use the methods and tools of research to, as I said, up our game and do it on a little bit more sophisticated and confident level.
Well, here's a question that I hear a lot on the road, and I'm sure you do as well. What advice would you have for private services or others who are laggards and don't see the need to even measure, let alone change? And then how do you raise an issue where people don't see a problem with status quo?
Well, I think some of that will be taken care of by the market dynamics. I think that once we start seeing payers in particular, whether it's private insurance payers or even units of local government, the city manager, the county administrator, the elected officials, as they start dialing into this information a little bit better, they're going to start asking questions beyond what was our response time. And when they're looking to approve annual budgets, they're going to start saying, well, what was the health impact that we had? Recognize you got there fast, but getting there fast isn't an adequate surrogate for providing good medical care. And so I think these kind of questions are going to start becoming more common in communities. And I think as soon as we start seeing that shoe begin to drop, it will dramatically influence organizational behavior. And along those same lines, I would anticipate seeing these kinds of clinical performance accountabilities being put into ambulance service RFPs and the contracts on the private side, or service level agreements that would be put in place by the city manager with the EMS director or the fire chief, that sort of thing on the public side. We're going to have more accountability for how we're using public funds, and accountability on the private insurance side to contain costs and improve quality under those alternative payment models. So those trends are beginning to emerge, and as those trends start becoming more apparent to everybody, and we start seeing chatter at the EMS conferences and the message boards and hallways about these accountabilities coming into place, I think that's when we'll start to see the behavioral change. And for those of you that are trying to disrupt the status quo, that's where I would kind of point people towards the archived version of this webinar and some of the other information that's coming out of the conferences to kind of help your EMS administration see what some of us are beginning to talk about and reading the tea leaves, and trying to prompt them to make those changes sooner or later.
And I would say, as somebody who also served as an operations director and had some board members that didn't necessarily have the vision, if you get your staff to look at this webinar and get a groundswell at a team meeting to talk about what are we doing about getting ready for the next generation. The frustration really is that some of the leadership has forgotten what it's like on the street, and they're not keeping up with some of this stuff here. So some of the people watching this will be smarter than their managers. So how do you convince the leadership or generate the interest to invest time and resources into a significant process or quality improvement program?
Well, sometimes you have to find champions to work through. If you haven't got the ability to perhaps influence the particular manager you're talking about, maybe you talk to your medical director, maybe you talk to other key influencers that have your manager's ear and make the argument to them so they can then bring it to your manager. Trying to be a change agent is a big challenge, and that could be the whole the whole subject of a whole webinar itself is how to catalyze change, particularly if you're a frontline employee in an organization. It's a little bit more challenging, but the takeaway I would give you is sometimes you need to work through others who might have more direct influence on your manager.
Yeah, and another takeaway I would give is that usually, particularly the people that are watching this right now, are passionate about this. Just go to your medical director or even your leadership and say, hey, I'd love to be involved in developing some of our processes. I'll do that, because a lot of places, they don't see the importance, but if they see your enthusiasm, they may just pick you to do that. What about programs like First Pass and other programs that do kind of a really deep dive on all your data, so it's not such a mountain of information for one person to go through, but the software does it for you?
No, that is a wonderful innovation and a wonderful kind of tool to have. What I observe a lot, AJ, is we'll see people in a designated quality role in a EMS organization or a hospital, and they end up spending almost all of their time and energy on just collecting the data, cleaning it up, getting it entered into a registry, generating kind of standard reports and whatnot. And by the time they get through all of that, they have very little time left to do actual quality improvement projects. And so if a lot of that grunt work, so to speak, could be automated, which it lends itself to, since we're using electronic patient care records very commonly now in the industry, and hospitals are very commonly using electronic medical records. As we start to see the tools become more available to integrate EMS and hospital data, that will kind of give us the basic information, whether it's out of a First Pass or similar sorts of tools. We'll have the dashboards there, and then you can see, here's how I compare to others in my state, here's how I compare nationally, and when you see that big gap, then you know that these folks must be doing something different than what we're doing here, and that's when you go out and do your benchmarking studies, find out how they're getting the results they get, and then try to replicate that within your organization to take that best practice into the fold within your organization, so to speak.
And for those that don't maybe understand what I meant by First Pass, it's a program by First Watch, and it actually takes all of your data and makes kind of almost a perfect milkshake. And you tell the system, tell me who has the best IV success rates, or tell me of this crew who gives, has the longest turnaround time, or who has the quickest turnaround time, even on the positive side. So it really goes through the data and mines it and gives you factual reports that you or your medical director want. So, look at whoever's doing your data and see if you have a linkage into something like First Pass, because it's really helpful. Mick, are there any
one more point? I was just going to say one more point about that, AJ, is we made reference to that eReports EMS tool. That's exactly what it's designed to do, at least for your AMI data, is digest all that stuff for you so that you'll kind of see how your processes are working for STEMI care.
Yeah, and I would point out, people throw at me all the time, but we don't have the staff to do all of this QA and QI. And well, the reality is the money that you invest in your software program and something that's proven, like we've been talking about here, pays dividends, not just on man hours, but also on potential liability. So you get what you pay for. There's a couple questions about specific books, material, or training that you recommend to further your QA/QI education.
Yeah, so one of the things that I would strongly recommend you do is follow the work of Dave Williams at IHI. Dave's a great guy, former paramedic, got his PhD and is now a senior improvement advisor with Institute for Healthcare Improvement, which I mentioned in the presentation. They're doing some wonderful work up there, and they've been doing some free webinars themselves on the IHA models for improving quality. So I would very, very highly recommend those presentations. The other thing that I would strongly encourage you to do is look for a local chapter of the American Society for Quality in your community or somewhere nearby. This is a wonderful resource to get exposed to quality in other industries. Like I said, a lot of this comes from the manufacturing side, and it's just been such a wonderful education for me throughout my career to kind of rub shoulders with other quality managers in other industries, and doing cross-industry benchmarking is extremely powerful. They have certification programs. They can help mentor you and encourage you, give you a chance to go visit their manufacturing sites or their service facilities and really have a chance to see how others are implementing quality in industries that are much more mature than EMS or even most of healthcare.
Yeah, and I know while you were talking, I went on Amazon Books and ordered Curing Healthcare, and they wanted $50 for it, but if you looked under the used book section, I got it for $5. So there's a tip of the day for you. Because I think we can look at that and other books that have already been around the horn a little bit. When will eReports EMS be available?
We're in the process of finishing some aspects of the build now, so I would expect we're probably going to start beta testing with some EMS agencies first quarter of next year. So I would expect probably maybe February or March, maybe early quarter 2 of next year is when you'll see it come out in general commercial availability, and we'll be doing probably a specific webinar with a demo and everything of that closer to that launch time.
We have a question here from Rachel. CMS pays so little for services now to providers. How's this approach going to affect the EMS providers that have poor or less than average quality? And then how do you base the quality when so many services have different budgets and can't afford some of the higher cost equipment?
Yeah,
kind of two questions
things
there.
Yeah. So if EMS ends up kind of in the same situation that hospitals find themselves in, you will see that the amount that EMS is paid by CMS will be influenced by how well you do on the quality measures. And that's several percentage points, plus or minus. Get a little bit more if you do good, a little bit less if you don't do so good. So there will be some economic incentives connected to these performance measures, again, like we see with the hospitals. That said, it begins to create the business case for making the investments necessary to do well on those quality indicators. And that's exactly what we saw happen with the hospitals when they were starting to be held accountable under that original joint commission program called ORIX that I mentioned in the presentation, and then with core measures later on from CMS. It started influencing how hospital administration allocated resources, and they started more seriously funding quality programs and paying attention to those numbers. And I would expect to see the same thing in EMS. And so for the organizations that aren't quite so well funded, what I would say is that a lot of these things don't necessarily require big capital investments. They require that you approach how you do business differently, that you start measuring your performance. And you don't have to have real sophisticated stuff to do this. I mean, back in the 30s when they started inventing all this, it was still pencil and paper. That's still possible to do. These tools and techniques that we're talking about, even though I use the word statistics, does not mean you have to have a PhD statistician to crunch your numbers. What you'll learn when you develop your quality education through like American Society for Quality, for example, you'll learn many of these simple, straightforward tools like fishbone diagrams and Pareto charts, et cetera, that you can do on a chalkboard, a whiteboard, the back of a napkin at the station. So it doesn't necessarily require a lot of money. It requires a change in organizational culture, that you are going to hold yourself accountable for measuring your performance on things that matter to patients and things that affect patient outcomes. And what has universally been found by organizations that have matured in their quality journey is that as they improve the quality, they find that their processes inherently become more efficient, and that's where their cost savings are. They find that this belief that many people have is that better quality costs more money is not true. It's in many cases exactly the opposite. You can significantly improve quality, and by virtue of doing that, you find that you gain process efficiency because you've cleaned your processes up. So it's not necessarily about the new widget you have to buy. It's about approaching how you measure and manage your organization focused on quality and efficiency.
But while we're talking about equipment, we had a really great webcast the other day by Bob Page on capnography, and he's kind of a guru on it, and I follow everything that he's doing. And he was talking about even now being able to use capnography in determining whether we really should be given Narcan or whether we can sustain and maintain the patient the way they are just by capnography. And it came up that there are many systems that are forbidding their crews from using capnography on a conscious patient because of the cost of the sensor. And I think that's utterly ridiculous, because it's as important a tool as what we didn't recognize before in pulse oximetry. So capnography, critically important, and your managers have to understand that. The cost of a sensor in caring for a patient should not be the determinant. Do you agree?
No, I would agree. And it might also kind of beg the question of if the sensor cost is part of the barrier, perhaps it's more efficient to use a side stream analyzer where the sensor is inside the box rather than at the point of the airway. So this is, the sort of thing that prompts those conversations is, if we want to use capnography and we need to use it more commonly, is there a more efficient way to do it on a day in, day out basis? And that's where you might do a QI project to evaluate the results and costs associated with side stream versus mainstream capnography approaches.
Great. Mick, what are some of the topics that you're going to cover in future webinars?
So we haven't nailed down the editorial calendar yet for all of the next year, but the next webinar, which we're planning to do sometime in January, haven't put down the exact date yet, but it's going to be about how to organize your agency to work with quality better. And it kind of speaks to a point that came up earlier with getting more people involved in quality improvement programs and the limited time that the designated quality manager has. We're going to talk about developing within the frontline staff of the EMS agency, clinical specialists that might take stewardship of, say, the cardiac protocols and review of cardiac equipment and monitoring cardiac quality, and maybe someone else takes on trauma, someone else takes on this, that, or the other thing, so that it isn't all about just the quality manager, the designated person in the front office. They might kind of be the coordinator, but pushing a lot of this responsibility out to the front line and giving people a chance to grow professionally. So how could you kind of reshape the structure of your organization to better accommodate quality is going to be a lot of what we talk about in the upcoming webinar in January.
Well, unfortunately, we don't have time to answer every question, but Mick gave you his email address, which I'm going to give you again, which is mick@improvementsystems.com. And please feel free to send him your questions. He'd love to answer them for you. And I have a couple of slides that I want to go over with you as we wrap up here today. There's more information about the new e-reports EMS system for AMI that'll be coming out soon, and the American College of Cardiology is going to have a webinar separate from this series to show it to you and provide detail about how to enroll, costs, etc. So be looking for that in the next few months. Also, there's more information on products and services from ACC for EMS and systems of care can be found at acc.org/eReports-EMS. I'm going to repeat that, acc.org/eReports-EMS. To receive an email announcement when the date is set for the next and future webinars in the series, please send an email with your name, the name of your organization, and your email address to ACC-webinar-series@improvethesystem.com. ACC-webinar-series@improvethesystem.com. So I want to thank everybody for your participation today, and particularly the American College of Cardiology and the Center for Systems Improvement for making this educational opportunity available. I think that Mick, no smoke being blown at you, that was a masterful presentation by somebody who's so passionate about EMS and about quality. So I think it's one for the ages. This presentation is going to be archived on jems.com/webcast within 24 hours, so you can share it with your colleagues. Please do that, because the more that we can get soldiers in this fight, the better off we're going to be at improving quality. It's your relatives, it's your parents, it's your friends that are going to be the next patients. So that's the reason that I'm driven behind quality, and I'm sure you are too. So thanks everybody so much for attending, and we hope to see you back for another great JEMS webcast soon.